Hi everybody, today we've got Dr. Phillip Kay joining us. Dr. Kay has had a very long and very fantastic career in the medicine arena. He was the first doctor to open a private emergency ward in Australia in 1987. He currently manages one of the largest university emergency departments in Queensland, as well as being the owner of a private emergency department, which puts him in a unique position to give us both public and private emergency perspectives. He manages a total of approximately 600 staff, and we are thrilled to have him here today. Hello, Dr. Kay.
Good morning. How are you?
Very good, thank you. We're going to talk a little bit about leadership in a crisis today. We're very interested in your contributions in this regard. And what are your organisations doing at the moment in terms of responding to this crisis, Dr. Kay?
Well, we're in the careful watch phase at the moment. We prepared really well and really early. With lots of daily meetings, getting everything sorted out, but then the tidal wave never came. And at the moment, we've got very few patients in hospital and little or no cases popping up in the community. So we're now transitioning back into the phase of some normal activity, which will be doing some procedural work and some elective surgery that doesn't use up too much protective equipment. And privately, and it's really not been in the press, but basically the activity of both hospitals have dropped phenomenally, 30, 40, 50, 60%, depending on which hospital you talk about. And they're paid publicly and privately on activity. So they've got gigantic infrastructure costs because they're extremely expensive facilities to run, and the revenue stream has dropped catastrophically. Now, we don't know what's going to happen about that, but that's a significant concern at the moment. Well, it's all about communication. We're having regular meetings in both hospitals with a whole array of experts, and then passing that down through a team structure into the individual department. And within the individual departments, there's sub-teams as well, managing specific areas. So it's a sort of a matrix cascading teams arrangement with the frontline staff being involved in the decision-making. They're not being directed what to do. They're part of the decision-making process. No issues really, because if you look at what's actually happening, the vast majority of the hospital's normal work's gone. And then it's been set up very extensively for the COVID tidal wave, which hasn't turned up. So there's a lot of spare capacity and a lot of spare staff, and actually no one's under any really pressure at the moment.
That's excellent news.
In Queensland, I wouldn't say the same for Sydney. Well, I hope so. I mean, all emergency departments, public and private, have had a significant reduction in their workload capacity. Some of the big public hospitals are down 30%. Now, a component of that is a group of people who are putting off going to the hospital because they may be afraid, and that's a concern, and the fact that they might be presenting later than they should. But the vast majority of people who aren't turning up are the people who probably shouldn't have been there in the first place.
Right.
With the government campaign for the last years that, you know, the emergency is a place for an emergency, not as a GP replacement or a convenience thing just because you want to get something looked at 10 o'clock at night. So the reduction in workload may transfer to a change of attitude as to what you do and don't go to emergency departments with, which will be a positive, because prior to the COVID thing, the growth in emergency attendances was phenomenal, outstripping the population growth and outstripping most of the predictions and putting stress on hospitals everywhere. You've got to say that the stress put on the hospital is not from the walking GP patients. They don't cause any hospital stress. They cause department stress. But the hospital stress is from people with multiple comorbidities and chronic disease that just don't function at home. Now, systems have been set up with telemedicine, etc., to allow those people to be treated at home, and that may be a huge benefit that might come out of this crop.
Are there any positives that you think that we can take away from this?
Well, washing your hands is a good one.
Yeah, next week.
We haven't been very good at that, and that's that may help reduce further normal flu epidemics, and the social distancing thing might be good as well. Well, just to put it straight, this is not our first one. We've had experience with swine flu and SARS and MERS before. This is probably the third or fourth one we've dealt with, so the systems have already been there. The difference between this and the others was the complete lack of cross-immunity and the fact that anyone who gets exposed to it pretty well gets it. So it was the speed of which it was spreading, which was the scare. Because all viral illnesses have a death rate of some form, either from pneumonia or heart infection or encephalitis or various things, but they all got a single-digit death rate at least. So, but it was the lack of immunity and the spread that was the problem. Now, but all the EDs have set up basically a bivalve system where if you've got respiratory systems, you go down the left-hand side, and if you've got normal problems like a broken ankle, you go down the right-hand side. So it's been split into, let's use the word clean and dirty or red and green or whatever you want to use. Mm-hmm. But as soon as this is over, that'll be scaled down. But until there's a vaccine invented and then that vaccine is widely used, then that's going to stay, because you only need one person to go to a wedding who's picked it up, and then you've got another 50 cases. Mm-hmm. So we'll have to remain on high alert with a lot of respiratory precautions and a lot of isolation until the vaccine's out, delivered, and the disease is fairly well eradicated. The problem is there's no immunity to this. So if one person comes from somewhere and has got it and goes to a party, then it's everywhere.
Mm. So what would be your thoughts on potentially, opening up areas where you can't move from that area, but you can still go to businesses in that space? You
mean like a silo?
Yes. If people weren't allowed to travel and there were no cases...
Well, any reduction in travel reduces the risk, but it's all mathematics.
Yeah.
Any reduction in travel reduces the risk. I think Queensland and the other states will keep their borders closed for quite a while. I think international travel of any form is an absolute no-no for months and months and months, because, America or China or anyone from England that comes over here could start another pandemic just with one case.
Mm. And do you think that we have the facilities that are appropriate at this point in terms of PPE equipment, testing equipment, all of those things?
Yes. Mm. And beds. I mean, most of the beds that we prepared for the tidal wave invasion of COVID patients are sitting empty. There's hundreds and hundreds of beds empty around the place at the moment, and surgeons standing around doing nothing. So that's why we're phasing in low-risk elective surgery.
Well, that's actually wonderful news. It's nice to have some positivity in these uncertain times. So thank you so much for your time and talking to us today about leadership in a crisis, Dr. Kay.